Hello, good evening, and welcome to the first session of Abdomen. So, before we start, right, all good, right? What I mean to say is that is the sound and everything is good. So, you can hear properly, everything okay? Because see, this abdomen, if you really see, I said this is like an AHA series. I'm good, I'm good. So, everything fine, right? You can see, you can hear, all good. All right. Okay. Yeah, Tanu, that's what I wanted to ask. I'm live? Okay. All right. So let's start with the abdomen. This is the first session. Now this would be one of the longest series. The reason behind it is that there is so much in the abdomen. So actually the other name of abdomen is Pandora's box, right? Jadu ka pitara. Actually it is like that, right? So this is like Pandora's box. Way back, right? When I heard this name, I liked it so much that it immediately stuck in my mind that yes, this is like a magic box. And actually you will feel so, right? As you will study, as you will progress, you'll really feel like that there is so much in the abdomen, right? Now, what would be our strategy? Our strategy would be, say, we'll start with osteology, right? We'll start with osteology. We'll talk about the bones. Now, pay very much attention, pay very special attention to the osteology of abdomen. In future, if you are interested in going in gynec obstetric, right? So this would be very vital. At the same time, this osteology will be playing a major role in many of the concepts, right? So once we complete our osteology, then we'll be completing the myology, that is the muscles, and the angiology, right? That is vessels. That is what we'll do tomorrow. Now, after this, we'll actually be learning the implementation, right? Now, what implementation is? We'll be learning about many procedures, angiographies, CT scan, MRI, right? Even the nuclide study. Now, you might ask that suddenly straight away the procedures. The thing is that no doubt, say for example, when we'll be learning about the say gallbladder, definitely we'll be talking about so many procedures which will be related to it, right? Cholecystography, etc. Yes, we'll watch it at that point, but I really want that you should be comfortable with all those names, and you should be knowing that okay, these are the things which will be coming on our path, and then we'll start with systematically one by one every procedure. So it's like, even if you are in first year, right, don't miss day after tomorrow's session as such. To none of the session, but say day after tomorrow's session, considering that okay, we'll be talking about CT scan, MRI, or radionuclide study, or angiographies, or in many of the procedures, right? Many of the barium procedures. No, they are important, and you'll be so comfortable as you'll proceed, right? So let's start. Let's start with our today's topic. Now, see, some of the portion of abdomen is like mathematics. I'll keep this Pandora's box because I like it. Right? Some of the portion is like mathematics. When we say osteology, right? The bones which are pertaining to abdomen, very few bones. One would be like those vertebrae, and second would be the pelvis. That's it, right? Uh, see, regarding any of the topic which are not related regarding this Bishkek, etc., we'll talk later. Yes, yes, yes. That's what I said just before a minute. That what would be that day after tomorrow when we'll be talking about all the procedures. If it is not applied, to then it is what, right? Definitely yes. All right, chalo. Let's focus now on the topic, because today again, as I say many a times, it's a long way to go, right? It's a long run, and actually abdomen is like a marathon. Okay. So regarding the vertebra, they'll be lumbar vertebra, correct? They'll be lumbar vertebra. Pelvis is right now, just keep it aside, right? We'll be discussing it in more detail. But let's focus on the lumbar vertebra first. Now see, these lumbar vertebra, will not learn the vertebra just, okay, these are the points, this is the size, etc. No. Let's understand it that way. Let's see, as the size, as the whole spine, it goes from top to bottom, the size of the vertebra, they keep on increasing because there is more and more pressure, right? So same way in lumbar vertebra, when we say there are 5 vertebrae, right? So L1 to L5, correct? In that, L1 to L4, they are considered as typical because their characteristics, they are quite similar. However, L5, it is atypical, right? L5 is atypical, or it is special. Why it has to be special? Because it will be carrying the maximum weight. So there would be something extra, something special, right? Now, in general, the characteristic of these lumbar vertebrae will be that they'll be large, right? Large size. Their size would be bigger. And most important point, who will be just above the lumbar, right? They'll be thoracic, right? In thoracic, there were all costal facets. True, costal facets, because in thoracic vertebrae, all those ribs, they were getting connected, right? Those ribs were getting connected. So over here, there won't be any costal facets because there is no question of ribs, right? All right. And one more important thing, that when we'll be discussing, say, head and neck, right? That is the cervical vertebra. So there would be the transverse process. In that transverse process, there is a foramen through which that vertebral artery goes. So obviously over here, because vertebral artery, it is not here, so there won't be any foramen. So no foramen in transverse process, right? So classically, this is the characteristic of cervical vertebra, and this is the characteristic of thoracic vertebra. And if they both are not present, so that means it is definitely a lumbar vertebra. So that is done, right? Now we can say, just if the vertebra is given in our hand, we say that is there any costal facet? No costal facet. And no transverse process, no, size itself is telling. All right, this is lumbar. Now the question comes, how to differentiate between this typical and atypical. Classically, this is how the approach should be, right? Okay. So first, let's see the typical vertebra, right? Let's see the typical vertebra. So when I say typical, this means we are dealing with L1 to L4 because L5 is atypical, right? So without any special introduction, right? This is the body, right? That is easy. Focus on this. This is what is called as the spinous process, right? This is spinous process, or the spine. You can also call it the spine, right? Now in thoracic, right? In thoracic vertebrae, those spinous processes, they were pointed, right? Very sharp, right? They were like this. That's how they were like. But as you approach towards the lumbar, right? See, do you remember? We talked about in I don't remember in which film, but yes, once we talked about the T12 vertebra is more or less like lumbar, because in the entire spine it never happens like that. This is thoracic, khatak, this is now lumbar, chalo, all the structures they are immediately to lumbar. No, things are gradual. So similarly, the spine which is in thoracic, which is long, slowly and gradually it starts decreasing, so that by the time when it reaches to 12th, right, it is pretty small. But then when it comes to lumbar, their structure starts changing, right? So this, pay attention to this spinous process. Obviously the body is large, we talked about it, right? Okay, moving further, this is where we are watching it from the side. Now from side there is so much to see, so much, right? One, this is L1 to L4, so typical. Okay, now in our body, if you watch from the side, right, the lumbar is like abdominal region. So abdominal region, it is like curve, right? It is like this curve, like this. So this is anterior. Okay, or let me draw it on the opposite, because with respect to this vertebra, right, so when we draw, right, it happens like this would be posterior, this would be posterior, and this would be anterior, right? And the structure is like this, right? Is like this, so curved, right? That's how it goes. Now, so how this curve is prepared? If you measure the distance, this is A, right? And let's keep this distance over here as B. We'll see all the parts, right? We'll see all the parts. This is just for our understanding that for the forward convexity, right? Forward, right? Of this lumbar spine, this A is greater than B, right? So when all of them, they will be staked, so it will give a shape. Now let's see these structures first, and then we'll be going into more detail. This is articular process, right? This is articular process. So it will articulate with what? Articular process. So this is superior. So we just give the name superior articular process and the inferior articular process. So it goes like, this. This is superior, right? And the above vertebra, right? Let's say this is L2, right? So this is L2 superior articular process. So this on top of it, it will be L1. So L1's inferior articular process, right? They will be in association with each other. So that's how they will be linked with each other. So superior, inferior, superior, inferior. That's how it goes. But watch something which is so interesting. It is this portion what I was talking about. You forget, it's like you forget everything, right? You forget everything, right? No problems, no problems. But see this one thing, this portion. This is the spinous process, and the spinous process in case of thoracic, which was very much pointed. Now over here, the classical word is, it is thick quadrangular plate, four sides, right? So it is quadrangular plate. So this is a big thing which we must remember, right? It will come, right? Just wait for some time. See, I would request one thing. At times, what happens, see, one can ask a question, what is a mammillary process? See, we have not finished the topic. True? There are so many things yet to come. So, well, I can always, means one can always ask, okay, what is mammillary process? How many ossification centers are there? How many primary and secondary centers are there? In that case, we'll be deviating completely from the topic. So what my request is that hang on for some time, right? Especially for abdomen, right? Because this is a first session, that's why I'm explaining. I'm telling this thing, that there is a flow. There is a flow of learning. It might happen. It might happen that sometimes in book it is given in paragraphs. Now over here you'll find this topic has not been taken. Yes, it will come, because we try to follow a pattern. A pattern is like, as we said, that when we learn one muscle, we learn something which is associated with that muscle, with third, with fourth, so that it becomes easy for us to understand, right? Thank you. Okay, so in thoracic it is more prominent. Sure, it is more prominent. Yes. Okay. So let's move on to yeah, the next point, right? So that is the thick quadrangular plate. Now, see, this portion, this is vertebral foramen, right? It is vertebral foramen and it is triangular, right? Not a big rocket science, right? It is seen that it is triangular. So what is this? This is superior articular process, right? Now you are comfortable with the superior articular process. The interesting thing would be they will be changing their direction. They'll be changing their direction, right? So like this, right? They'll be changing. About this vertebral foramen, it is largest in cervical. It is largest in cervical, right? Then comes lumbar, and then comes the thoracic, right? Then comes the thoracic. So do remember this part, that this vertebral foramen, right? That is how it goes. This is for typical, right? Typical lumbar vertebra. So this means L1 to L4. Fine. Okay. This is all right. So we know this part, that okay, this is body, that is superior articular process, vertebral foramen, right? And this spine, then that is inferior articular process, and we hang on for other points. Yes. Now let's discuss the rest of the points, right? Because see, now we do have the base of body, superior articular process, vertebral foramen, spine, and inferior articular process. So these many points are known. Now it becomes much easier to understand rest of the process. First thing first, we'll see what exactly is pedicle, right? Any of the vertebra, it is divided into two parts. One which is body, and second is rest of these all those chota structures from the posterior part, right? They all unite together to form that entire vertebra. In the ossification, we'll see that how these structures, they all are developed individually and then they fuse, right? So let's start with the transverse process, right? This is the transverse process. That is okay. Color change. Okay. So that's transverse process, right? This one is the transverse process. This transverse process, now as there are no ribs, right? So this transverse process is thin and tapering, and actually this process, it represents like ribs in thoracic region, right? But here there are no ribs, so it really happens like that there were ribs, and then because these lumbar vertebrae, they were crying that we don't have ribs, so that's why they were given those transverse process ke theek hai le jao, right? A small portion of bone is given to them. You tell them that they are similar to ribs, right? They are similar to ribs in thoracic region, right? Because they were crying, "Okay, we are not given ribs," so God said that, okay, take this. But then where is the transverse process, right? Where is the transverse process? So see, this is the accessory process, right? This is the accessory process. Name given is accessory process, right? But they are big hearted, right? They are actual transverse process, right? So they are true transverse process, right? So we'll tell them true transverse process. They are true transverse process. Now these transverse process which are over here, we are talking about this. As you go from L1 to L2 to L3, then to L4 to L5, right? Their length increases from L1 to L3, and then it starts decreasing from L3 to L5. Baby ribs, that's a good name, huh? Baby ribs. About this transverse process, this baby ribs is good. Let me write. They are they are like baby ribs. Okay. Hmm. So their length, their length changes, right? And say, okay, so this is heart, right? Accessory process, big heart. All right. Next is that lamina, right? This lamina is what is connecting the spine, and it is actually completing the arch. It is actually completing this arch, right? So it is short and broad, right? And it is broad lamina. So that whole thing, when it forms, it is called as the neural arch, right? It's called as the neural arch. This entire thing, right? This portion, right? That's how it is the neural arch. Okay. We'll be talking about neural arch once again also, right? When it will actually come for those ossification. So this is easy, right? Now we know that this is transverse process, that's the body, that's the spine. See, spine is that thick vertical quadrangular plate, right? Then those big hearted accessory process, superior articular process, inferior articular process, and this inferior vertebral notch. Let's keep it one aside. Inferior articular process. That's right. It is the spinal cord which will be passing through vertebral foramen. You are right. Right. I would be talking about spinal cord bit in more length, right? Because we'll be discussing even the applied part also today. Okay. So where were we? Yeah. Inferior vertebral notch. Right. Now see this way. This is one vertebra, right? When it is then to second, then three, then four, right? That's how it goes. So when it is connected with the vertebra below, right? So here is inferior vertebral notch. The idea is, what we need to remember is that this inferior vertebral notch is deeper than superior vertebral notch, right? That's what we really need to remember. So this inferior vertebral notch, it is deeper than superior vertebral notch, right? Okay. One more thing. Say the distance between inferior articular process, right? Inferior articular process. Let me take it one back. Yeah, here. Say this is the inferior articular process. Sorry. I'm really sorry. It is very difficult to explain in Hindi. because it's not so that my Hindi is very bad. Yes, sometime I'll speak in Hindi, right? Sometimes. But as such, say it is good to understand in English. Not that I don't respect Hindi, but it is like, say, English is an international language, right? And there are so many friends over here for whom Hindi might be difficult. And second, even in case if you're finding some difficulty, see the things twice, thrice, four times, you'll definitely understand. Then what happens, that it comes into your second nature. You start learning, you start understanding it much faster, because as you will progress, right, when you, no one is going to, let's say, take your USMLE exam in Hindi, right? Finally, so it is, everything will boil down to English only. So that's why it is necessary. Where we can see superior vertebral notch, I'll show you, right? Is vertebral foramen and neural arch is same. Well, vertebral foramen is a space and neural arch is the bone which is surrounding it, right? The bone which is surrounding it. So that is what is called as the neural arch. See, this bone is neural arch, right? This bone, sorry, should I change the color, right? This bone, right? This bone is neural arch. Foramen is this space, correct? I'll just remove this so that it is what point which was there, that this inferior articular process, right? These two inferior articular process, they are nearer to each other as compared to superior. Getting it? Right? So when it is L1, so in L1 superiors are like this, inferior are like this. But then slowly and gradually it will keep on changing, so that in L5 things would be reverse, right? Okay, so all right. Okay, so inferior articular process, I'll just write that for typical, right? This is typical. For typical, it is nearer than superior, right? Superior articular process. Now, when we'll see L5, immediately you'll see the difference. Okay. Yeah. This is, first we are watching this L5. When we say this is atypical, and when we say it is atypical, first thing which we would like to see, that this distance, right? Okay. This distance. Okay, I'm just, because so that it can be seen clearly, so I am drawing over here this distance and this distance, right? This is between, they are superior articular process, and that one is inferior one, right? Inferior articular process. To make our understanding easy, we just give this name A and B. And what we say is that in case of L5, B is either bigger, greater, or equal to A, right? I think this will be sufficient, because what happens is it will give stability. It is for stability, right? So that's the reason. This one, the distance between inferior articular process is equal to or greater than the different distance between superior articular process. One more important thing, what was that? This was that transverse process, right? Transverse process. Yeah, that this is like baby rib of L5, right? And I like that name. So this I'll use it every time whenever I'll be explaining these vertebrae to anyone. Who said that? Right? I'll try to remember his name also. I'll just check it out. Okay, so this is thick, short, and pyramidal. Right? Thick, short, and pyramidal. Very stout. Because though now it is not looking like a baby rib, right? It is looking like a Dadagiri wala rib. Anyway, so moving on to this, yeah, again, this is a atypical, right? Just we are looking from the sides. Body is largest, large body. In fact, largest, right? Largest. This is L5, and that's the, say, superior articular facet, right? Now, this superior articular facet, classically, it is facing backwards. It is facing backwards. What was happening in case of those typical ones, right? They were facing obliquely. Now this is facing backward, right? So do remember this. This is facing backward, backward, and backwards. And these are inferior one, correct? And as you must have guessed, right, this inferior articular facet, they will be facing forward, right? They'll be facing forward, forward facing, right? And what about this spine? Now this spine has become very humble because he is the last candidate. After that, the sacrum comes. So it's a rounded spine. It's not that like quadrangular plate, right? So these are classical of L5. Right? So we know this we go for quickly. Body, vertebral foramen, superior articular process, that's the transverse process, that we must draw that heart, right? Accessory process, inferior articular process, spine, and that's lamina, and these are the mammillary process, which are the projections. Okay, let's go further. This is, say, superior vertebral notch and inferior vertebral notch, right? Now you know it, correct? So that's the superior vertebral notch and inferior vertebral notch. Inferior vertebral notch is deeper, and we talked about it, right? It's deeper, and that's the spine. This is the transverse process. Spine is rounded, correct? Right? It is rounded. That's the transverse process, mammillary process, and the superior articular process, right? All good, right? Yeah, this is L5, right? Yeah, it is king of lumbar vertebra. But big boss is about to come, right? He's about to come, and he is so big that even this L5 would look like bacha. About these muscles, don't worry much. I have put them over here just for the reference, as I want to draw certain extra things, right? So that it will give reference at a later stage. So just don't worry much about, say, anterior longitudinal ligament. In fact, we'll be watching anterior longitudinal ligament all the way, right? So it is like when the vertebrae are staked one over each other, right? This is anterior, correct? Or this is anterior, right? So for the stability of all those vertebrae, there is a ligament on the anterior side which will be connected to the body of all the vertebrae, and that is anterior longitudinal ligament. Not a very big thing, right? In any case, we'll be watching cross of diaphragm. Trust me at this point, right? When we'll be discussing diaphragm, there is left crust, there is a right crust, and there is so much to learn about those crusts, right? So just keep it as it is. Psoas major, yes, now you know psoas major, right? That business partner of iliacus. So that psoas major, that's over here. Now it is just a different angle, right? Otherwise we have seen that psoas is coming all the way like this. So this is the point, this is exact location, and here is the psoas fascia. Do remember this, right? Because we'll be talking about psoas abscess at a later stage. This will be of importance. So psoas major, that's a muscle, right? Then we do have that quadratus lumborum, right? Quadratus lumborum, you are comfortable with that. And these are the all lumbar fascia, right? So there is an anterior layer, there is a middle layer, and then there is a posterior layer. Well, it makes sense, right? It makes sense because here is the anterior layer, right? That's the one which is in between is the middle layer, and this one is the posterior layer, correct? That's the posterior layer. Erector spinae, this is a muscle which is of the back. Yes, we'll be discussing it, right? We will be discussing it, and it would come. This multifidus, all those are back muscles. All of them will come. I want to add something to this, and that is over here. There is a very one interesting ligament which will be over here, right? And there will be one more ligament which would be over here. If we want to really give the name of this ligament, right? So then this one, if this is anterior, so then we'll be calling this as the posterior longitudinal ligament, correct? That is, and we'll watch all of them, right? We'll watch all of them in real sections, right? So posterior longitudinal ligament, and this one, see, deliberately I have used the yellow color because its name is ligamentum flavum. Flavum means yellow, right? Flavum means yellow, right? We'll see all these ligaments. Right now, just remember that there is something like this. Okay. Psoas minor is not seen here, right? Okay. The next topic now in this, regarding ossification. This is a topic, at times it becomes very confusing, right? So let's keep it simple. Let's make it simple. There is a primary ossification center and there is a secondary ossification center, right? Primary is something which is developing before birth. So for these lumbar vertebra, say this much small vertebra and so many ossification centers, yes, but that's the beauty, right? Say in this, there are three primary ossification centers. One, which is called as the centrum. Centrum means just in the middle of the body, That is what is called as the centrum, right? And second is the neural arch. Now it makes sense, right? It makes sense, right? So neural arch would be right and left, correct? So that makes, so this is one, this is second, this is third, and done. Three primary ossification centers. How come? Let's draw it. So this is the body, just in the middle of it, right? That ossification center develops. And rest is all cartilage, right? But it is this neural arch, right? This is spine, these are the transverse process, all they are softy, all those cartilage. But yeah, here is the one, and one here, one here. So these are the primary ossification centers. They fuse by the end of 1 year. Ossification is same for all. I think you are asking for L1 to L5. Yes, right? I'll just write L1 to L5. I hope I have guessed your question correctly. Same for all means same for all vertebra, all lumbar vertebra. Okay. So this is 1, 2, 3. Yeah, that's 1, that's 2, that's 3, right? So that's how they develop. They fuse by, right? They fuse by first year, right? They fuse by first year. Appear, so they appear very early, means almost say by the 9th week of development, right? They come up. Now in secondary, there are 7 ossification centers, right? 7 ossification. Now in order to remember that, right, we need to take support of the figure. Then and then we remember, otherwise so it is very easy to forget. So let's draw the vertebra from the side, right? So if we draw from the side, so then this is what? That is spine, right? This is the body, correct? So that's the body, this is body, and that's the spine, right? Spine or spinous process. I'll just write spine. This is side view. So here we start, right? The first ossification, one, it is above, right, in the circular form, like a plate on the body, above the body, below the body. Third one is at the spine. So here it is, this is 1, right? That's 2. The spine is 3. Then that transverse process. Now transverse process, we do have right and the left. So that is 4th. This one is 5th. And finally, those projections in the form of mammillary process, right? So they are again right and left. This is 6 and that is 7. Remember, these secondary ossification centers, they appear by 15th year and they fuse by 25th year. Correct? Right? Fused in first year, that means after it is left like that, or is something formed over there? Actually no. Actually no. I didn't get it. What are you trying to means? See, basically it is cartilage, right? And then this cartilage that converts into bone, and then finally the whole structure is created, right? Yes, yes. So then the whole structure is created. So that's how it forms, right? And importance of all these things is, like, in case if you come across any of the bone, or when you take x-ray, so from x-ray you can say determine the age, right? So it is important from the forensics part. Okay, moving further, moving further. Now this is a term, sacralization, right? It is called as the sacralization of L5. When this L5 is fused with sacrum, right? Because just after L5 there is a sacrum, right? This could be asymptomatic. Means many a times it is asymptomatic. You might not even know, and how you come across, just casually you have taken the x-ray and you come across it. So radiologically you figure it out. But sometimes if it presses L5, right? In fact, 5th lumbar nerve, right? This is 5th lumbar nerve. So that gives pain, right? That gives a low back pain, and which we classically say that it is sciatica, right? That's sciatica. Sciatic is something which we'll be discussing, right, in depth over here. Okay. Now, say we learnt ossification, right? So that neural arch is forming that entire portion, right? Here was the spine. But what if this neural arch is not developing properly, right? They fail to fuse. So if they fail to fuse, right? Failure to fuse this neural arch, so then it is called as spina bifida, right? So failure to fuse neural arch, right? Neural arch. So they don't fuse over here. So there would be a space. This is what is called as the spina bifida. Spina bifida. Do remember these keywords, right? So it happens like that when now inside, so there is spinal cord, right? Then there are meninges which are covering, right? So if we really see that, okay, this is the spine, then it is covered by that pia mater, and then there is another layer which is called as the arachnoid matter, right? In between this space, this dotted where I'm doing, so that is what subarachnoid space. That is where you will be finding cerebrospinal fluid, and then surrounding it you have got the tougher one, and that's why, because it is very durable, that's why it is called as the dura mater, right? And the space which is underneath this blue, right? So that one is called as the subdural space. That's where dural sinuses, right? Dural sinuses are there, and that's how the entire spinal cord, right? It is there. Now these are all called as the meninges, pia mater, dura, arachnoid mater, dura mater. So when there is a space, there is herniation of meninges or spinal cord, right? It depends, right? So yeah, outer is dura, right? Yes, sciatica is related to sciatic nerve. Yes, primary ossification. That's right. Okay, so this, because of the spina bifida, there is herniation, right? There is herniation of meninges. Now it could be meninges and or spinal cord, right? Spinal cord. So there are different terminologies which are associated with that. When we say that meningocele, right? Meningocele. This means what? That it is the meningeal protrusion, right? So meningeal protrusion. So when these meninges, they are going out, so obviously that subarachnoid space would also go out. So there is CSF, so it is with CSF, and when it is that protruding out, it will actually increased intracranial tension, because as such, so this entire system is connected, right, all the way to the top. So that is what is called as meningocele. When we say meningomyelocele, right, when we say meningomyelocele, so over here it is meninges which are protruding with CSF plus spinal cord. This is more serious, right? This is more serious. That is spinal cord. When we say myelocele, this means that that spinal cord is open, right? It means that those neural arches, they were like this, and yes, straight away you see the spinal cord, right? You see it. This is open spinal cord, right? And when we say spina bifida occult, occult means all those studies, right? So this is called as spina bifida occulta. Occulta means hidden, something which is not very much known. So this spina bifida, it is hidden. How is it hidden? Because it's like this. It's like this. Here is the spina bifida, but the skin is covering it. So as such, it is hidden, right? So there is spina bifida, but there is no swelling, right? Spina bifida is there, but no swelling. So that is what is called as the spina bifida occulta. Now, as because of all these variations, right, there would be several abnormalities like say scoliosis, kyphosis, lordosis. So it is just in which direction the spine is. Scoliosis is when it is sideways, right? Say this is left, this is right. So let's say spine is bending on one side, right? All of these are very painful things, right? Typically because they destroy the shape of the body. Now, in kyphosis, this is, if this is anterior, this is posterior. So then there is hump in the back. Hump, you must have seen, they walk like this and there is hump in the back, right? Like that camel, it is hump in the back, right? And lordosis is that in lumbar region, so it is inside, right? There is a inside. Instead, the spine is like in the lumbar region, it is going out, right? So this is anterior region and this is say lumbar. So that is what is called as the lordosis, right? Okay. So L3, L4, L5, L5, right? It has slipped forward. It has slipped forward, right? Maybe because of anomaly of any of the ossification. And when this thing happens, right, it results in back pain, right? It results in, and the pain is similar to sciatica, right? Because those nerve roots are involved. Yes, kyphosis is in the hump. That's right. Okay. Now this is maybe because of, say, fracture. This is the symbol of fracture, or say dislocation, right? So there is central disc protrusion. Disc protrudes. Now this can result, because it will be straight away compressing roots of cauda equina. Cauda equina is the last portion of that spinal cord, right? So when this thing happens, the symptoms, they are classical, right? Sphincter disturbance, right? Person would be finding difficult to hold his urine, right? So stool and urine, right? That is difficult to control. It can affect, so their impotency, right? There would be anesthesia, right? Loss of sensations. There would be paraplegia, right? So all those things, they can occur for the lower body. Yes, it will, once when we'll be discussing the nerve supply, etc., it would be still more clear that why it is so important. Sometimes this disc degenerate, right? So it is the degenerative process. This is like a degenerative process, and when the disc degenerates, right, it is very common. It is common in two regions. One between C5 to C7, that is cervical, right? And the lumbar, L3 to L5, that is between L3, L4 or L4, L5, right? They are very common. Now, I'll tell you something very interesting about it. Over here, when this disc, right, it is degenerated and it is compressing the nerve, right? It is compressing the nerve over here, right? Initially, the pain is high. Initially the pain is high because this disc is going touching the nerve, right, and it is irritating it, so that becomes painful. So there is increase in pain with coughing and sneezing. But in case if the patient gives the history that now there is no pain, so beware, because now the disc has absolutely locked the nerve, so there is no relative movement between disc and the nerve. In such cases there is less pain, but that doesn't mean, and you can see these things very clearly in MRI, so that doesn't mean that patient is improving, right, if there is decrease in the pain. Okay, for this test, how to check it, right? So patient will be telling that there is loss of muscle power. Loss of muscle power, right? Pain is there, definitely pain is there, but loss of muscle power. And to test it, this is what is called as the straight leg raise test, right? I'll just write straight leg raise test. This is also called as Lassig's sign. Now, if we slightly go into more detail of it, because when you do this test, there is something which we need to know. Let me add one page, right? Because we need that. No problem, right? When I'll save the PDF, I'll take that page up. Right? So regarding this straight leg raise test, what you'll do, here is your patient, no pillow, right? No pillow. He should be lying straight. And then you raise the leg, right? Now this is, remember, this is a passive raise. Passive raise means you'll not tell the patient that you raise the leg, right? You will take his leg in your hand and then you will raise it, right? So that's why it is called as the passive raise. Now then the patient complains of pain, right? Now if this pain, right, he'll complain, if this pain is less than 30 degree, right, less than 30 degree, right, so that means you are dealing with something which is in the gluteal region, right? It could be gluteal abscess, right? So patient will be giving history of fever, etc. There could be tumor of the buttock, right? Or it could be, say, disc protrusion, right? Disc protrusion. All these things can occur. If it is between 30 and 70 degrees, right? Normally, it is with our current scenario, what we are discussing. That is lumbar disc herniation, commonest, right? Lumbar disc herniation. So that means disc has herniated or prolapsed, and that is what giving. So this is the classical thing. If it is after 70 degrees, right, not to worry much. If everything is fine, so it is because of the tightness of hamstrings, right? Tightness of hamstring muscles are tight, or the gluteus maximus is tight, or the hip joint capsule, right? Person has not done the exercise, so hip joint capsule, right, that is tight, right? Paralysis, right? So hip joint capsule is tight, or there could be some pathology of hip joint or SI joint, sacroiliac joint, right? It could be there, but commonest is this, right? Rest of the things I just told you, that you keep in mind that yes, it is all related to SLR, right? Straight leg raise. Okay, so this was scoliosis. All right, this is kyphosis. That's just the image itself is telling everything. And this is lordosis, right? Okay. This is for your reference, right? Just two things which we need to, that this angle, right, which is called as the subpubic angle or the pubic arch, right? This is subpubic angle. We'll be talking about this angle because it is wider in case of females and it is narrower in case of males. This is to differentiate between the hip bone of male as well as female, right? So here it is the hip bone, sacrum, all L4, L5, right? Things are well known to you. So we go quickly to the next part. That is sacrum and that is all hip bone, right? You know this part. That's sacrum, right? So sacrum, right? This is ala of sacrum, correct? Ala, that is wide upper part, and because it supports weight, right? It supports weight. Gluteus abscess is when there is collection of pus, right? So supports weight. All those are pathological things, right? Because in gluteal region or how it occurs, etc., it is a long topic. So just this part, right? This prominent is promontory, right? Do remember all these. Sacral promontory, right? The prominent part on sacrum, because that's what you will be understanding when we'll be discussing in just 2 minutes about pelvic inlet, pelvic outlet, pelvic cavity, right? Everything would be so important. And yes, this is like that smiley, right? So this is the pelvic surface. That is the pelvic surface, right? And this one would be the apex, right? After that, there would be coccyx. Okay. So sacrum, as such, if you see, these are all sacral vertebra, but they are all fused together, right? So we can say just fused 5 sacral vertebra, right? Becomes much easier to understand. All right. In any case, right? Say, what is this lumbosacral trunk and medial sacral artery? Don't worry. We have not yet touched those vessels, right? So we need not worry. We just see piriformis. Yes, we know that piriformis, right? That's multi-muscle, right? This coccygeus, yes, it will come, right? This is glomus coccygeum, ganglion impar. Nothing to worry. All these are they are part of that neural supply when we'll be discussing about it, right? This iliacus we know, right? We just figure out what we know. This ala of sacrum is known to us. Obturator now, yes, we know that, right? This is lateral mass. Rest, leave it. Just leave it. Don't worry, right? It will come. Here it is. How he actually looks like, right? This is how the sacrum looks like from behind. So this is the posterior surface, right? This is the posterior surface of sacrum, right? Here it is. This is superior articular process, because it would be, see how it is almost like facing posteriorly, right? Because inferior articular process of L5, that will be articulating with it. But here the interesting part is this. There is a canal, right? That's what is called as the sacral canal, right? That is called as the sacral canal, and it is triangular in shape, right? So over here we do have like S1, S2, right? It is this level, right? Inside, if you go inside, so that at the level of say S2, what really happens is, that is at S2, subdural and subarachnoid spaces, they end at this level, right? So subdural and subarachnoid, they end at this level. So now the lower sacral nerves, right, they pierce dura and arachnoid and then they go. So this is very important, right? So over here, all those nerves which will be coming out, right, they will pierce. So lower sacral nerves, right, none of the other nerves, they will be going like this. It is only the lower sacral nerves, they pierce dura, right? Obviously, if they are piercing dura, also arachnoid. So and arachnoid, right? So that's the important part. Yes, again, just for our familiarity, superior articular process, we saw that. These are like fused lamina. Yes, surely, because all the L1 S, these all sacrum S1 S2 S3, they are fused. Yes, erector spinae multifidus, we know that these are the muscles of the back, so no need to worry. That is auricular surface. Yes, we have heard of it. Gluteus maximus, all right, right? Sacral cornua, sacral hiatus. Sacral hiatus means it is that opening. Above was sacral canal. Phylum terminal, right? That is over there. Inferior lateral angle, but obvious. Regarding the tubercles, all those tubercles, these are the lateral and the medial sacral crest with sacral tubercles. That's okay, right? That's okay. Nothing much over here. Let's move further. Okay. For this, again, for this ossification, right? Ossification of sacrum. Ossification of sacrum. For S1 to S5, some are common, right? There are 5 vertebrae, so these are the common for them. These are the common ossifications for them. One, as we said, centrum. Centrum means it is that body, right? It is for everyone. So 5 bodies, right? S1, S2, S3, S4, S5. So there would be 5 ossification centers, primary ossification center. Then we know about neural arch. Yes, we know about it because same was the pattern for above, right? And then there is right and then there is left. So there are 5 on right side, 5 on left side, and this tells the total 15 primary ossification centers of sacrum. What's the big deal, right? So simple. But let's add something to it. For S1 to S3 only, S1 to S3 only, right? The lateral mass, right? The lateral mass, their sides, right? They are in the form of like that coastal bars, right? Those coastal bars, like those false ribs. So coastal bars, both the sides, both the sides, bars, both the side, right and the left. So 3 on each side. So total 6. So thus 15 plus 6, total 21 ossification centers. Plus there are some secondary centers, right? Easy. One above, one below, right? So this is 1, this is 2. True? Plus, so total 10 because we are dealing with 5 S1, S2, S3, S4, S5, right? So total 10 plus for the auricular surface, right? We saw that auricular surface which was articulating, right? There are 2 and plus 2 more for the margins, below. So there are 2 more, right? So thus 10, 12, 14. So total 14 secondary ossification. And these ossifications again, they appear at around 15 and they fuse at 25th year, right? Same pattern. As such, if you see, there is not much difference in the pattern. It is quite similar. Yeah. Because abdomen is pretty long, so that's why we'll be having slightly longer sessions, right? Okay. Now we see that because say if we don't finish the topic today, then it will be hanging for tomorrow, and tomorrow we need to cover still a bigger distance, right? So we'll try to finish it. Not much, it will not take much time, right? Because as such you have learnt most of the things. Say this is like sacral index, right? Sacral index. So how to calculate it? It is the breadth across the base, right? Maximum width, or you can say breadth or the width at base, right? Multiplied by 100 and divided by length from promontory to apex, right? The length, that is from above to below, right? Length. So it's like, this is like that sacrum, and over here it was sacral promontory to this was the apex. So right, that's the distance, and that is what is called as sacral index. And classically it is, in case of males, this sacrum is like this. That's the shape. It is long and narrow, right? Long and narrow. Quite logical, because in case of females, right, it is like this. It is like this. It is short and wide. So every time whenever it's like male pelvis, right? Male pelvis is short and narrow. There is less space, right? But obvious in case of females, right? There has to be more space. So that's why it would be wider and more circular, right? So this is for female and that's for male. The second important point is that sacrovertebral angle, right? Sacrovertebral angle between the sacrovertebral angle, sacrum and vertebra, the angle formed by sacrum. In case of, right, this is angle. It has to be, right? If you see the curve of the female, right? The curve of the female, right? This curve, right? It is surely more prominent in case of female as compared to male, right? So in case of females, this is more prominent. When you know these things, you'll understand that why the female body is like female body and the male body is like male body, right? Yeah, there are maximum ossification centers. That's right. Okay. Now this is that Bichara last one, right? He is telling that say something about me also. These are all coccygeal vertebra, right? Coccygeal vertebra. There are four, right? So last four coccygeal vertebra, and we need to say this is coccygeal cornua. Cornua means like horn, right? Coccygeal cornua, right? So just for the sake of giving name, this is CO1, coccyx 1, 2, 3, 4, right? Just let them be happy, right? 1, 2, 3, 4. And just this one, right? It is like, okay, I do have transverse process. So just let them be happy that yes, you also do have transverse process. It is like CO1, coccyx 1. Now there is one last topic which is called as the pelvimetry. And I tell you, when you know pelvimetry, right, it is what is going to give you the cutting edge, because that is where everyone would be confused. There would be lots of confusion between true pelvis and false pelvis. What is pelvic inlet? What is pelvic cavity? What is pelvic outlet? Right? Especially when you are studying the stages of labor, right? When the baby is getting delivered, when it is passing through all those stages, at that point, this would be of immense importance. So, pelvimetry, right? There are several methods. Pelvimetry, measurement of pelvis. One, what is called as the skeletonized, right? You have got the skeleton, and from that you measure. Second is clinical, right? Clinical. In clinical, external or internal. These are the two methods. External means anterior iliac spine, posterior iliac spine, right? All those prominent points, you just take that and then you try to measure it, which is not very accurate, right? For internally, that is per vaginal examination is needed for this clinical pelvimetry. And the third thing is radiological. Radiological. That is with the help of ultrasonography, USG, right? You do the pelvimetry. So thus this thing will be a tremendous importance in obstetrics, right? Obstetrics. Then in forensics, and obviously in all those anthropological, when they study various type of pelvis, and whether it is from apes, whether it is from animal or it is from human, etc., right? All those anthropological. Let's see this, right? Just three figures and it is done. First, we are understanding pelvic inlet. See, it's actually very easy. It's actually very easy. Unnecessary. They have given all those lengthy descriptions to make it complicated. As such, though, it is so easy. It's in fact so logical. For any of the structure, we need to find anteroposterior diameter, transverse diameter, and the oblique diameter. But that's it. This is what is needed. So over here, when we say that, say, just a minute, if it is there, if it is there, so let me show you that part first. Okay, chalo, no worries, no worries. Next time I'll show you, I'll give you one more figure, right? Let me draw it over here. Say in pelvis there is a false pelvis, and then there is a true pelvis, right? There is false pelvis and true pelvis. And just for few minutes, do remember that this is what is called as the pelvic brim. Brim means edge, right? So anything above the pelvic brim is false pelvis, below is the true pelvis. What is pelvic brim? We are about to see that. Don't worry, right? We are talking about it. Ossification of coccyx, in fact, it is very similar to other, same like other bones, right? Okay, now let's focus on this. Inlet, pelvic inlet, right? So from top, it means, see, there is abdomen, and then from abdomen, the pelvis starts, right? Abdomen is over, now the pelvis starts. So when would it start? With the sacrum, right? Here is the sacrum. That's the sacrum, right? So which was the most prominent portion, which was right in front in sacrum? Sacral promontory, right? I told you, do remember this. So that was sacral promontory, prominent sacral area. So it is here, right? It is here. We are taking the midpoint, obviously, right? Because that's the point from where we'll be measuring the distance. Okay, we are dealing with AP diameter, antero-posterior. In front, what is that? It is pubic symphysis, right? Because that's where the entire hip bone is made up of ilium, ischium, pubis. So when those two pubic bones they meet, so that is pubic symphysis. So we are just taking the upper border, right? Remember, upper border, because from there the real pelvis is starting, right? So we are just taking this and I'm writing it over here. Say pubic symphysis. Okay, let me write it full. Pubic symphysis, upper border, right? So I don't think there is any problem, and we draw this. It is not straight. This is better. This is AP diameter, right? Antero-posterior diameter, because things are curved, right? Now there is another name of this AP diameter, right? I'll write it on the side so not to mess up with the figure. So this AP diameter is also called as the true conjugate. True conjugate, right? Because when the baby has to negotiate this path, when he'll be entering, right? He'll be entering into the pelvis, so it has to negotiate this path. Everywhere, right? Everywhere, inlet, cavity, and the outlet, right? It would form an axis. That is what is called as the pelvic axis. That is the axis which baby would be following for the delivery, right? Okay, so this is good. For the transverse, Transverse is easy. It is the highest possible diameter, the largest transverse diameter, right? Or the longest transverse diameter. Okay. What about the oblique part? Now see, for oblique, this is the point. Which point is it this? Because that's where ilium and pubis, right? Ilium and pubis, they are, from here comes the ilium, from here comes the pubics. This is iliopubic eminence, right? Or the prominence, the prominent portion. This is iliopubic eminence, right? Iliopubic eminence. To the opposite SI joint. This is what? Sacroiliac joint, right? SI joint or sacroiliac joint. And this one is the oblique diameter, right? That's what is called as the oblique diameter. Right now, I am not entering into that what is the length of each and every, right? That would come. But first we should know that where exactly the pelvic inlet is. Now comes the second part. This is mid cavity, right? So this mid cavity is where all diameters are equal, because now this is a cavity, right? This is a cavity, right? So that is the mid cavity. So here every diameter is same. So what is over here? Say in between it would be S3, right? S1, S2, S3, S4, S5, right? So this is the midpoint of S3. And then on the anterior side, that was symphysis pubis or the pubic symphysis, right? Symphysis or pubic symphysis. But now that pubic symphysis upper edge was there. Now we are going down, right? So this is where we are taking the posterior surface. Posterior surface. Makes sense, right? Makes sense. This is the posterior surface, because now the cavity has already been formed. So we are in sacrum also, we have gone down. So similarly on the pubic symphysis also we have gone down. And over here, as we go down, do we find that obturator membrane, right? Obturator foramen, right? Obturator membrane which was covering obturator foramen, right? And on the opposite side, the lowest point of sacroiliac joint, because now the sacroiliac joint is about to get over. So this is the lowest point, SI joint, right? That is the lowest point of sacroiliac joint. So that's how this is what is called as the mid cavity. And then the outlet, right? The outlet. This is real interesting. The outlet. In the outlet, first thing first, identify the structures, because if you don't identify structures, it is damn confusing. First, we are talking about this point, the most prominent point on which we sit. That is what it is, ischial tuberosity, correct? As we said many a times that we really sit on ischial, everyone sits on ischial tuberosity. Okay. So if this is ischial tuberosity, so what is this? This is sacrum, right? This is sacrum. So we need to give some name. We need to give some name to this ligament, sacrotuberous. From sacrum to tuberosity, so this is sacrotuberous ligament, right? Ligament. Till this point, everywhere there were bones. Now take the midpoint of this sacrotuberous ligament, and over here, this is what? This is pubis, right? This is pubis and this is ischium. So it is ischiopubic rami or the ramus, right? Am I right? This is ischio-pubic rami. So from that point to midpoint of sacrotuberous ligament, that's the oblique diameter. And then ischial tuberosity to ischial tuberosity, that is the transverse diameter. So that's the transverse diameter. See, actually it is not that complicated, right? If you try to visualize, it is much easier, right? Pubic symphysis, obviously it will always be there, right? On the back side, we started with sacral promontory, then we took the middle point of S3, and then we are over here. For the AP diameter, we are taking this coccyx tip, right? Coccyx tip to over here. Previously, we took the upper margin of pubic symphysis, then we took the back surface of pubic symphysis. So now we are almost on the outlet. So we have to take this point as, no wonder, pubic symphysis, where inferior margin, right? Inferior margin. So that's actually the inlet, mid cavity, and the outlet, right? So when we said that pelvic brim, right? What is pelvic brim? Because anything above the pelvic brim is considered as false, because this is all abdomen, right? That's okay that hip bone has started, but that doesn't mean the pelvis has actually started, right? Hip bones are here, right? But the real pelvis, it starts from here, because after pelvis there is perineum, right? We'll study it in more detail, right? Because there are lots of structures, everything is to be, but this is what you need to know, that what is that level, what is this level, right? That level is sacral promontory, right? From sacral promontory to upper part of pubic symphysis. Now, do you remember what was that? When we said sacral promontory to pubic symphysis, upper part. Right? Upper part. This is nothing but it is like AP diameter of pelvic inlet. Right? Exactly. Right? This is the AP diameter of pelvic inlet. Now this is day one, right? I'm overloading you a bit. Sorry, but it is needed. But what was the other name of that AP diameter of pelvic inlet? What was the other name of AP diameter of pelvic inlet? As I said, this is very important, must remember. And what was that? Sacral promontory was anterior? Yeah, sacral promontory is anterior. Obviously, it is anterior. So what's the other name of AP diameter of pelvic inlet? If you say, I'll be very happy, right? What's the name of it? It is true conjugate, correct? It is true conjugate. All right. So as we said that female pelvis, right? They are also called as the, yeah, that's right. So they are also called as the gynecoid pelvis. Right? Male pelvis, they are also called as the android pelvis, right? They have got nothing to do with cell phones, right? They are called as android pelvis. The only difference is that this female pelvis, they have got the round inlet, right? Round inlet, and they are wider. right? The side walls, they are more vertical, right? Say side walls, right? The mid cavity, right? They are more vertical. That's the reason that it has got more space. In case of male pelvis, the its shape is like this, right? As it goes down, it is like a funnel shaped, right? It is a funnel shaped. It is narrower. And at times I say that when you'll be studying pelvis, at that point you'll realize that physiologically female body is more complicated and much more advanced as compared to male body, right? Because so many structures and there is so much of integration into that, and that's the reason where the space is needed, so that's why it is wider. Just for the theory part, there are anthropoid and platypeloid, right? All those pelvis, but they are just for those apes and right, all those monkeys, etc. Right? So not to worry about that. Few quick differences in case of male and female pelvis. Once what we said is that regarding the false pelvis, right? False pelvis, that means pelvic portion which is above the pelvic brim, right? Pelvic brim, that is sacral promontory to upper surface of the pubic symphysis. In case of say female, right? In case of female, right? They are like shallow and they are quite deep because it is like the structure which is formed like that. Just one more point first we need to talk about it. The shape of the pelvic inlet, then we'll say inlet cavity, right? That way we go. So pelvic inlet. In case of females, it is rounded, right? So that was the sacral promontory and this is the pubic symphysis. While in case of male, it is triangular, right? It is triangular, right? That's the sacral promontory and that's the front. When we talk about the cavity, right? This is the pelvic cavity. We said that this is shallow, right? This is shallow, while this is it is wide, right? In case of female, it is wide. Another important point, the third one, the outlet, right? Outlet. Say ischial tuberosities, right? If you really see ischial tuberosity, this is vital, very important. They are inverted. So they are like this, they are inverted. So thus there is less space. But in case of female, they are everted. So thus they give more space, right? So ischial tuberosity, they are inverted, and over here they are everted, right? So these are the three important points must remember, must remember. Rest of the things, they are pretty quick and easy, right? The sacrum, we talked about it. The sacrum in case of male, it is triangular, right? But it is narrow. This is in case of female, it is wider, right? Similarly, we saw that subpubic angle, right? It was that subpubic angle. For the purpose of delivery, yes, in case of female, this is wide and pretty wide, right? 80 to 85 degrees. While in case of male, it is pretty narrow, right? But obvious, it is 50 to about 60 degrees. Then that acetabulum, right? Acetabulum, it is large, right? Because thicker bones, bigger bones, more powerful, and over here it is relatively small. There is something what is called as the chilotic line. Now then this chilotic line, it is line which you draw from iliopubic eminence to iliac crest, right? You just draw it. It is actually, I'll show you the chilotic line after some time when we'll be discussing it in bit more detail, right? But just remember, iliopubic eminence to iliac crest. So if you see iliac crest, right, it is going all the way to iliac crest. So there is a pelvic part and there is a sacral part, right? The pelvic part and the sacral part. So actually when the bone is in your hand, then you can really measure it. So over here in case of female, this pelvic part is longer because see it is more roomy. Pelvis is more roomy, it is wider, right? So that's why the pelvic part is longer and the sacral part is shorter. In case of male, both these are equal, right? So that's subpubic angle. Subpubic angle, well, here it is. Chalo, you have asked and it is over there. That's the subpubic angle, right? Subpubic, just below the pubis. So that's the angle, right? That is subpubic angle. So greater sciatic notch, ischial spine, anterior pubic ligament, right? And pubic tubercle, coccyx, pelvic inlet. That's how it goes, right? So this is sacral promontory and the pubic crest. And then few of the images I have kept just for your reference, right? Just for the understanding. So over here you can actually that, okay, what is, say, what is this, what is this, what is this angle, right? All those things just for the revision, right? So these are all unmarked figures. Say here, this is when you watch it. So actually this is pelvic inlet and this one is pelvic outlet, right? So this is pelvic outlet. So that's it. That's it for today, right? Thank you so much. And we meet tomorrow, same time. Thank you and bye-bye. And I'll place this file into our shared folder. I have already created in that area the abdomen notes, right? A folder is there, so I'll be putting it as 1_abdomen osteology, right? So that way we'll keep on putting all the files over there. Good night and bye-bye. File has been saved.